to start us off. This section is the advanced practice providers and registered nursing. We're going to be talking about staffing and workload. I'm Liz Fox. I am an advanced practice provider, both a CNS and acute care NP, and I work in the neuro ICU at Stanford. We'll have you guys introduce. You want to go?
Karen Seagraves. I am the Executive Director of Neurosciences for the Grady Health System and soon to be the Vice President of Neuroscience for the Atrium Health System.
I'm Audrey Rango, soon to be Audrey Shealy, and I am the System Director of Neuroscience for the Neuroscience Service Line for CarePoint in New Jersey.
And Karen's going to be talking about the stroke unit, and Audrey will be talking about IR. So if questions come up, just stop us. We can have some dialogue throughout. All right. So in my section, again, focusing on neurocritical care. For nursing, we're going to talk about orientation, competency, and education. We'll talk about staffing and ratios, and then relate this both back to standards as well as regulatory requirements. For advanced practice providers, we're actually going to pause and say, why do we even need advanced practice providers in a critical care setting? What do we know from the data? And then again, finishing with some standards and regulatory requirements. So standards about nursing, the first place I went to was, what does our professional organization, Neurocritical Care Society, recommend? And this is a paper that's actually relatively new that delineates level 1, 2, and 3 neurocritical care units. Level 1 being the highest level of comprehensive neurocritical care, level 2 being a center that can handle most types of cases, and level 3 being an organization that stabilizes and then transfers. But it actually is pretty prescriptive about what types of elements you need for neurocritical care regarding nursing. And I think you guys have access to the slides. The image is a little bit tiny there, but it does talk about ratios that I'll share in a little bit more specifics in a minute. It talks about specialty certifications, whether that's stroke certified, neurovascular certified. It talks about certifications and recommends ENLS. It talks about orientation, nurse-sensitive quality indicators as well. So pretty prescriptive from our professional society about what a nurse should look like in a neurocritical care unit. It even goes on to talk about specific skills that the nurses need. And again, this would be done through orientation and competencies. But it talks about drains, family support, which is interesting. I think that it's listed within the skill set, but drugs, fluids, advanced neuromonitoring, et cetera. So again, pretty prescriptive about the skills a nurse needs within neurocritical care. There's also a lot of regulatory standards, and I think some people in here may be more familiar with this than not. When we talk about neurocritical care, oftentimes we're talking about comprehensive stroke centers. The two sets of regulatory standards I'm going to share with you are DNV and Joint Commission. Not promoting either product, it's just these are the two organizations that tend to certify the most comprehensive stroke centers around our country. The first standards here are from DNV, and this talks about training of a staff nurse, okay? And it talks about both orientation and annual competencies, okay? Pretty generic, if you will. This, more detailed, is from Joint Commission, and there's 6 of them there. It's pretty early this morning, but there are 6 of them there. And it actually goes on specifically to talk about evidence-based stroke care, knowledge of the stroke scale, ICU competencies that I'll show you on the next slide. And then it does give a suggested number of, more than suggested, I guess, but a prescribed number of continuing education hours each year. So more detailed, I would say, than DNV. And very detailed here is the list of skills an ICU nurse needs according to Joint Commission. So again, it goes on neuro and cardiovascular assessments, drains, hemodynamic monitoring, thermal regulation, pressors, lytics, et cetera. So this is a little bit closer to what Neurocritical Care Society actually is saying as well. Okay. No matter what, though, when you boil it down, you go back to the basics. And whether it's DNV or Joint Commission, you can really say, what does a nurse need to be onboarded, oriented, competencies, and then annual education? If we take away all the letters and alphabet soup of it, really it's about these 3 areas. Each year is an organization for a neurocritical care unit. The plan may change, right? If you bring in a new device, your competencies may look different. Onboarding orientation may look different each year as well, but you should have a very prescribed plan that's approved by leadership for your nursing. So staffing. I thought this was interesting actually when we started getting into what type of staffing is supported both in the standards as well as regulatory requirements. And we go back to the Neurocritical Care Society standards paper from 2018. It says that neurocritical care should mirror an ICU, a critical care unit. So should be 1 to 2, but then there should be additional acuity criteria for 1-to-1 staffing. And the examples that they list in the paper are there. So advanced cardiac, neuro devices, multiple vasoactive infusions, ICP issues, status, acute spinal cord, and then neuromuscular diseases. So again, just a few examples of acuity-based that may drive the patient to one-on-one care. DNV, I'm sure Karen's going to talk more about the stroke unit, but their actual standard there is only a note saying ICUs are generally 1 to 2, okay, 1 to 2 staffing. And then Joint Commission is actually silent on the staffing of ICU patients with nursing. Okay. So shifting gears to APPs. So why do we even need APPs in a critical care setting, right? This is a relatively new, acute care nurse practitioners have just been in since the late 90s. So we can look at it in 4 areas: our aging population, our physician shortage, how residents impacted critical care, and patient acuity. So as far as our aging population, the 65 plus has over doubled in the last decade, okay, from about 40 million to over 80 million. So our population is aging. There's more people that just purely need ICU care. Physician shortage, by 2020, the need for critical care intensivists will be over 4,000, yet there's about 2,000 in practice right now. That's a huge discrepancy. Okay. Resident work hours, ACGME back in 2003 cut the working hours from a basic 30-hour shift, which doesn't make sense regardless, but down to a 13-hour shift. That's in half our resident workload, okay? Which is the right thing for patient safety, but then how do you have enough providers to care for these patients? And then patient acuity, we all know that the patients in ICUs don't just come in with a nice stroke and that's all they're there with. They come in with heart failure, an MI, or renal failure. They're very complex patients that need multiple interventions. So this perfect storm and why we need advanced practice providers in order to actually staff our ICUs in our country. So what do we know about using APPs in the ICU? The literature I'm going to talk about is actual general critical care. It's not specific to neurocritical care because there's actual minimal literature on that right now. It's a relatively new phenomenon to use APPs in neurocritical care. So again, I'm going to reach for the global critical care literature. There are quite a few studies that actually put APPs head-to-head with physician providers to look at outcomes. And it's been shown, there's 2 more recent papers that are actually systematic analysis, both by Klenpel and then Kreftenberg, that actually show mortality and length of stay. There is no difference between a physician provider and an APP, as well as satisfaction, home disposition, ED to ICU transfer time, lab costs, 14-day readmission. All of these, when you put them head-to-head, an APP is equivalent to a physician provider. There's also additional quality and patient safety literature that demonstrates APPs actually have reduced UTI rates, reduced DVTs, and early identification of sepsis. So a slight indication that maybe APPs are a little bit more compliant with some of our regulatory things. What data do we still need? A lot of the studies I just told you are head-to-head comparisons. What's not in the literature is the unique APP role and really demonstrating a value of APP. So if I happen to have enough physician providers as an organization, why do I even need an APP? We need to describe that better in the literature ourselves. Okay, we're not just a physician replacement, but it is a unique role. We also need better outcome measures that actually show the value and impact of an APP. A lot of the things, right, are just medical sensitive outcomes, but what actual APP outcomes could we look at? And then we need to better understand the 24/7 coverage phenomenon. I was talking to Ann this morning, and I was on night shift earlier this week, and we rotate back and forth, and not exactly sure how healthy that is for the APP community, but unfortunately the neuro ICUs do need 24/7 coverage. In a recent observational study that was done through Neurocritical Care Society, it actually showed that in the US, 73% of ICUs use APPs in our country. And then they also looked at Europe, et cetera, and the US has the highest utilization rate. It was really interesting to see that. But in that, we really need to describe specifically the value of APPs. So beyond the outcomes I just showed you, there's further literature to talk about. We know what the outcomes are, they're equivalent, but actually how do you integrate an APP? That is also lacking in the literature. This article by White talks about staffing integration, onboarding, and then performance. Staffing, there's really not much about ratios. Onboarding, how do you even onboard an APP? Does anybody remember their onboarding? I shadowed, and that was really it. So we really don't have a good structure for onboarding, and again, performance. How do you evaluate an AP performance? Oftentimes it just falls straight into the medical staff, but there's a lot of other job responsibilities that the APP does that we're not actually evaluating then. So ratios. We talked about the nursing ratios, which were a little bit more clear. In APPs, I had a hard time finding any of this literature. There is one study that was done again by Kleinfeld. She's published a lot in critical care APPs, but it was a descriptive study, basically a web-based survey, and it had about 400 responses in it, and they came up with, in an ICU, the ratios range anywhere from 1 to 3 to 1 to 8. So that's a big range there. For comparison, typically an intensivist or a physician partner would be 1 to 13, and on nights 1 to 24. A lot of variables that go into the ratios, including patient acuity, number of providers, number of beds. But overall, 1 to 8 was the provider ratio for patients to APPs. So standards, what type of standards do we have to help support the APP practice? Again, within the neurocritical care paper from 2018, there's a few comments on there about APPs, not as much as nursing, but basic clinical care, nursing consultation, evidence-based practice. They do comment generally on orientation and ongoing evaluation, but it's not as prescriptive as nursing. Looking back to our regulatory standards, so Joint Commission does have 2 standards that relate to advanced practice providers. The first one is if they're part of 24/7 coverage, they need appropriate training and they need physician backup in essence, okay? And then the second bullet is actually they need to have an advanced practice provider. So when we go back to some of the comprehensive stroke establishment papers, they actually demonstrate the value of an APP, which is where this standard comes from. DNV has a similar standard, just saying you must have an advanced practice provider within your CSC, but again, not as detailed as the Joint Commission requirements. Okay? But nothing in either of these on orientation or competencies, right? So a little bit of a black box there. All right, some references, and then I'm gonna hand it over to Karen. I think we'll take questions at the end.